Last talk in this session for another break is Stephanie, so we'll hand over to you.
Thank you.
Thank you.
Can you hear me okay? Yeah. So just to introduce myself, I'm Dr. Stephanie Craig. I'm going to give a slightly different talk. I'm actually an academic and I lecture in precision medicine over in the Cancer Centre. So today I'm going to put the question to you. Could artificial intelligence replace molecular diagnostics, so current healthcare practices? So the first question is, for you guys is, what is molecular diagnostics? So if you've ever went to the doctors and they've taken a sample, it's sent off to a lab. So that molecular diagnostics is the analysis of that sample using molecular markers, either protein, DNA, or RNA, and either a tissue from a biopsy or fluids, so for example, like blood. So have any of you had a sample taken at your GP? Yeah, we've all been to the doctors. So my particular interest is in cancer research. So when these samples are taken for cancer assessment, there's loads of different tests that are run. So, and these are used to give you personalised medicine, to make treatment more targeted to you. There's not a one-box-fits-all for patients. Some of the tests that are run are diagnostic tests. So this is working out if there's cancer present and what type of cancer there is. If you're a man over a certain age, you might be screened for prostate serum antigen to see your likelihood of having prostate cancer for further examination. So it's a non-invasive type test. We also can have prognostic biomarkers tested for in these samples. And this here is a picture of a patient who has an advanced head and neck cancer. So late stage, so obviously not as bad as bone, head and waist is right now, but prognostic biomarkers for head and neck cancer is a thing called HPV infection. And if a person, and whilst that looks quite bad, if they're actually HPV positive, they have a 60% chance of living for 5 years. If they're HPV negative, they've only got 20% chance. So these biomarkers can be really powerful for helping the clinician explain to the patient what their outcome is going to be when they're diagnosed. And we also have predictive biomarkers. And this helps us to work out what kind of treatments are the best to treat that cancer with. And if you know somebody with breast cancer, you might hear them talking about their hormone receptor status, if they're negative or if they're positive. And what this means for us as clinicians is that their tumour is expressed in a certain type of protein that can be targeted by a therapy. And even though HER2 positive cancers are quite aggressive, if you give them this specialised treatment, they're going to respond really well. And actually, they have a 93% chance of living for 7 years. And I think it's 80% chance of 10 years. So it's really good patient outcomes for them. And there's lots of tests that are ran in these samples that came. So not just one of these tests we ran. However, in the UK alone, over 375,000 new cancers are diagnosed each year. So it's more than 1,000 cases a day are reviewed across the UK. That's actually quite a heavy workload. And what we're experiencing at the moment is actually a loss of pathologists in clinical medicine, just because they're aging out of the system, and it takes around 10 to 15 years to train a new pathologist to consultant level. So one of the things they're doing and how computer sciences and engineering is coming into the field of medical practice is the modernisation of pathology services, which is my particular interest. We're seeing automation of practice through patient samples coming into the clinic. Instead of previously them being hand-dipped and assessed manually, they're being put on automated platforms. And this helps to standardise the testing across the UK. So one sample could be assessed here, same way in Glasgow as in London. And this increases capacity because they can be run overnight. We're not requiring somebody to stand at the bench and physically dip slides. And it also reduces turnaround because these machines can run overnight and you're getting this consistent result. So this is the automation side we're doing with computer scientists and engineers to make this software work, but we're also getting digitalization increasingly. So these samples that are created are now being put into digital scanners. So instead of pathologists assessing these using a microscope, they're basically put in the microscope in a box that's creating a digital image that can be assessed by a pathologist at their computer, at their desk. And this actually helps to datify the patient sample. So rather than being a physical slide, it's now data, it's now information. And that means we can actually apply data analytics that we've discussed today and all the other methods and from other fields to these cancer patient samples. I'll touch on that in a second, but it also allows for remote reporting. So instead of me physically sending my sample to get a second opinion to somewhere in Newcastle, I can just send them an email attachment and say, look, can you confirm this is a stage 2 adenocarcinoma? Rather than me having to physically send the sample, wait for the post to deliver over there, and it might get lost in transit. We're still working with snail mail for a lot of pathology services. So one of the things, even though we're having this modernisation of services and the automation and digitalisation is making things a lot easier, one of the problems we are having is that a lot of the tests we're using, and the ones I mentioned earlier, aren't all created equal. And what I mean by that is that the assays we have available, the accuracy can differ significantly on how it works. For example, I mentioned prostate serum antigen. It's really sensitive. Actually, it's too sensitive. You get a lot of people being referred to, well, their clinician tells them, you might have prostate cancer. We're going to send you for more invasive testing. And actually, it turns out most of the time they don't have a prostate cancer. They just have a high PSA level. So it's a too sensitive test. But it's better to be more sensitive than lack of sensitivity. And what you tend to find with the really good sensitive and specific tests, they're actually less likely to be available in every single lab, and they tend to be more specialised and sent to reference laboratories, so that there links into then this longer turnaround times because you have to send your samples away. And having access to these different tests with different accuracy leads to pathology bias in reporting because you're not all working off the same spreadsheet essentially. So essentially what we wanted to ask ourselves, this is the research I work in, is could we do these tests better by using artificial intelligence? Because we're datifying this information, we can actually then break up the images into their component parts and process them through, like any data set, an artificial intelligence network. Now, this particular example is for deep learning models, but we have also ran machine learning and random forest on this type of data. This is a sort of pipeline we do to get our final result, which is our positive or negative prediction of a tumour being present or a particular biomarker being present. So this is great. You know, we don't need to train pathologists. We can just train computer scientists. They're going to make these models for us. It's going to make our lives much easier. That, you know, save loads of money in the NHS. But this gives a question I want to ask you. You know, it's kind of pathologist versus machine. There's actually quite a big problem with the pathology community because they feel like people are trying to steal their jobs on the computer scientist side. But you obviously know the limitations in AI. Would you rather an expert talk to you about having cancer? Or would you rather have an expert opinion computed for you? And there's pros and cons for both of these for your cancer diagnosis. And some of the factors to consider, which was talked about in the diagnostics talk, was the data quality making these models. So for example, in pathology, you know, your staining protocols, even though they might be automated, can create significant variation across labs. So this is a tonsil sample, different tonsil samples for different sites within the states. You can see how different, how purple and red some of these look, even though they're all tonsil cancers. You also have differences with image capture. Some labs might use a camera mounted on a microscope. Some might use one brand of a camera, of a scanning device, and some others might use a different one. And this can lead to difference in the image quality because these different cameras have different image pre-processing techniques to make them either look more like a dynamic microscope or more native digital images. And further to this is our problem with the ground truth labeling. Depending on access to tests, people might use a surrogate biomarker to determine, you know, is cancer present or not? Is HPV infection present or not? They might use a DNA-based test. They might use an RNA-based test. And you can see how different those look in those images. Or they could use a genetic test, which can have a very different result altogether. And because, let's face it, we're talking about the NHS, there's a lot of pressures, financial pressures in the NHS. These image files aren't very cheap to make. For one file, you can have 2 gigabytes of data. But you know, if you can get away with taking something at 20x magnification versus 40x magnification, you're halving that size of file. So yes, it's only 1 gigabyte file, but remember, we're having 1,000 cancer cases a day. One of those cancer cases might be associated with 50 slides. So that's 50 slides times 1,000 every single day of data being generated, and it has to be stored for at least 10 years. So we're going to come into data problems within the future within the NHS if we go digital. And I should say, actually, quite proudly for Northern Ireland, we're the first country in the world to go completely digital for pathology services. So we're kind of leading the mark for this. But to make these models, there's resource-intensive initial outlay that's kind of limiting why they're being used. And further to that, you know, if you're talking to a human and you're getting diagnosed for cancer, you have somebody to blame. If you're using an AI model, who's to blame if they diagnose your cancer wrong? You know, at present, you've got your cancer type. Pathologists can tell you, oh, there's a tumour present on this slide. It looks malignant. With the AI model, we're just getting a graph based on some parts of the image. So part of the research we're doing in my lab is looking at, you know, heat map analysis of what really in the image is causing this to be, you know, tumour positive, tumour negative, and what parts of those images that we're using to pass through the model are really being used for prediction of cancer. So just to conclude, I don't know if I've been able to demonstrate to you, but just a show of hands, based on the evidence presented here, do you think AI could replace molecular diagnostics and get pathologists out of a job? Yes, put your hand up. No, yes. So some people, yes. I completely agree with you. It's unlikely they will, but there's a really great opportunity for computer scientists and people working in machine learning and AI to work closely with people in the medical industry, and we're looking for people to help us improve patient care and outcomes. So thank you very much for listening. I'll take any of your questions. And just point out, I work as a team, multidisciplinary team, so coming to work for something like this here, yes, it's academia, but it's a great opportunity to work with clinicians and really make a difference to patients in the UK. So thank you for listening.
Got a couple of questions. Bear with me. No, it's good. It's better for me, let's be honest. I know there's snacks coming.
Do you find that there is a correlation between false positives by analysts and by computer-generated kind of models?
Yeah, there definitely is. So that comes back to that ground truth. If the pathologist doesn't annotate the stuff properly in the first place, pathologists don't agree all the time, by the way. There's a great degree of disagreement between pathologists, and you'll see about half the time they disagree. And actually, when they're doing reporting clinical cases, if one pathologist says, I'm not sure about this, and the other person doesn't agree, they'll actually come to a consensus. And what happens, because it's so resource intensive to label this data in the first instance, half the time it's only done by one person. And so you're not seeing that same level of agreement and consistency that you get at a clinical case for during a clinical meeting. And that's contributing to the poor quality of these models. And just to point out, so I've mentioned the genetic analysis there. People are now looking at using AI to determine a thing called microsatellite instability status of patients, which is a very key prognostic factor in colorectal cancer, normally done by genetic testing. They're now looking to use H&E images to predict those genetic outcomes. And the problem for people annotating for the pathologists is they've never used pathology images to annotate for a genetic test like that. So how do you know your ground truth is actually good? It's not a clonal area, and you've actually included a big area that's not really relevant to the models. You're diluting your data. So that's why you're needing so much data in these models. So yeah, there's definitely a correlation with how good that data is. That might be biased by what tools pathologists has available to them to annotate the data. Answer your question? Yeah.
Thank you. Yeah, we've got another one up the back here.
Yeah.
Great presentation, thank you. My question was, do you see a sort of hybrid approach in the future where you have working together, and will there be a level of training required, for example, for clinicians to then engage with this technology moving forward?
Yeah, that's actually a great question. So probably one of the benefits and negatives of being the first people to do it is they've put a training program together now, and one of the first questions they've actually asked the pathologist is, can you report the same result for a patient sample on a screen, not even using the AI, just looking at the screen compared to a microscope? So they're going at a really slow level, so it might be 10 years when we're asking that question. But the way this college is looking at the moment is they're doing pathologist training with the digital platforms, but they're also looking to train up the biomedical scientists, the people who run the tests, to prepare the data for the pathologist to review. So starting to bring in not the less trained, but different people in from different fields. So yeah.
Hey, I just have a question. A few years back, I saw, I think it was actually Cancer Research did like a gamification thing where they had like citizen scientists taking part in this game, and it was identifying particular cells and all. I haven't seen that for a long time. Was that actually any use, or is it still any use, or will it be in the future, or is that redundant now?
Let's say the PathLic initiative, because I know PathLic's one of the big consortia in the UK, so Queen's is part of that. Mm-hmm. And that was one of the things they did. So that's to do with the data labelling. So the great thing about labelling data is that we'll use it at some point in the future. So if you label data as part of that, it probably will be used, I'd say.
So the gamification does actually work, that model? Because I mean, what I gathered from it was they were taking where most people picked the same things. I think it was like Space Invaders or something.
Yeah, basically.
Yeah. So most people picked the same thing. They just basically took it if it was within a certain range, and there's a good chance you should look at it. Is that the way? It was just narrowing it down, was it? It wasn't like, yeah.
Yeah, that's exactly.
And that's still happening then? Yeah,
those types of research is still happening. It's like I'm saying, is how do you know where to look at in the image? So that's why it's really important to see where the pathologist is looking. Like, I know we talk about AI models being black boxes, but you see when you meet a fully trained pathologist, it's also like talking to a black box. Because they go, oh, it's a cancer. You ask them why, and they go, because I know it is. So it's very similar. Is that
Good. Great, thank you. That was fascinating. And I'm sure I'm not the only one now doubting what I do for a career. So thank you very much.
Thank you.